Good evening, everyone. My name is Caden. I work closely with Ryan in the sales and marketing here at DIBS AI. We're excited to introduce the February DIBS AI Study Club tonight. Just so you all know, we are recording this session, and it will be available on the DIBS AI support website under the Deep Learning tab, which is under the Support tab. Today, we are turning to some of our favorite topics, which is how to integrate CBCT into your DIBS AI cases and to see how that increases efficiency. So we appreciate Dr. Lana Helms for being willing to share her insight and how it's used CBCT integration. She does almost all of her cases with CBCT, and she has done well over 700 cases with DIBS AI so far. So just a little background on her. She helps teach at Indiana University. She's a great customer of ours here at DIBS AI, and we appreciate her. Just so you all know, this is an open mic meeting. So if you have any questions, please feel free to use the questions tab and go ahead and answer or type in those questions, and we will do a Q&A towards the end. Anyways, with that being said, Dr. Helms, a great DIBS AI power user, we'll turn the time over to you, and we appreciate you. We'll turn the time over to you now, Dr. Helms.
Can you hear me?
Yes, we can hear you.
Okay, perfect. Okay, I think my video is disabled, but that's okay. I'm gonna go ahead and share my screen. Okay. So can you see my screen now?
Yes, yep, we see it. Thank you.
Okay, all right, perfect. So I'm gonna do a presentation. Thank you for having me and asking me. This is something that I really enjoy talking about. So I was excited for the opportunity to be able to share just my experience with indirect bonding. And just by way of introduction, I'm a graduate of Indiana University School of Dentistry, 1995 DDS, and then I also did my master's degree in orthodontic residency in 1997 at IU. So I'm happy to share my story with indirect bonding with DIBS software using cone beam CT root integration. When I was trained in 1997, we lived in a 2D world. So we used panos, Ceph measurements, and plaster models. I had excellent training in burstone mechanics, biomechanics, and I had a pretty good idea of how to move teeth. Another thing from my era was smile aesthetics was just coming into the picture, largely through the influence of Dr. Vince Kokich, and then later also Dr. David Sarver. And these early influences, I think, still affect today how I treat patients. So allow me in these first few minutes to just share some things that have influenced my indirect bonding journey over the last 25 years. And yes, it was probably about 25 years ago when I first got into indirect bonding. I'll talk about that. So you're going to hear several company names. I nor any of my family members have received any compensation to say anything or mention any company names that I'll be discussing in this lecture. So why indirect bonding? Because there are some drawbacks, and I think it's important to acknowledge those. It's more time intensive on the front end to set up a case. There are expenses involved. And if you're like me, when I first tried indirect bonding in 1999, a few failures on each case caused me to give up on indirect bonding. In those days, I was experimenting with the Sonde technique, and we used a plaster model, and we positioned the brackets on the model and then made trays. But by the time 4 or 5 came off, 3 to 5 brackets came off per arch, it just didn't seem very efficient for the time that was put into it. So one reason that we do it is for our team. So here's my team, all 17 of us, and this is my associate, Dr. Jeff Roberts. Indirect bonding has made their jobs more efficient, and especially when there are two doctors that are seeing the same patient pool. I think also we do it for our patients. If orthodontic treatment takes less time to initially bond, and I think your bonding can be quicker, less clinic time, I think in our case, it does take fewer appointments for the patients, and then probably less time per appointment. It's going to be a better experience for them. So another thing that I believe in is the indirect bonding reduces bottlenecks in the treatment progress. You know, we all have experience with how inefficient it is when someone is in a finishing wire and there are several bends in it, and the patient comes back in with a bracket debonded. So indirect bonding for me has improved the bracket positioning from the day of bonding. So a little trip back through time. In September of 1997, I was a young professional just graduating, excited about getting started with life, and I wanted to return to my hometown of Washington, Indiana, which is where I still practice today. It has a population of about 11,000 people. So it's a very rural area in southwestern Indiana that I practice in. I had student loans to pay from school, and you know, there were no practices in the area that I wanted to live in that were available to purchase. So I remodeled a building and purchased equipment and started a practice. I was also a newlywed in 1997. So I got married in 1997, and I had some big dreams. I wanted to have a family. I needed a profitable practice in order to pay my student loans and my bills. And of course, coming out of my residency, I wanted quality finishes. That was something that, you know, I think we all come out of residency with knowing what a quality finish is and wanting that. So a little story about my family. I married my husband. He already had a son who was 11, the same year that I graduated. Then in 1999, we had a son. 2000, we had a daughter. 2004, we had twin daughters. And 2008, we had our sixth and final child. So just some fun facts about my family. Here's a picture of some of our family at my daughter's Marine graduation from Paris Island last year. So we can check the box on family. It was a busy time, but my practice steadily grew through those first 10 to 13 years after graduation. Most of my time was involved in caring for my young family. So in the last 15 years, I think this is kind of where my journey in seeking some more efficient practice methods began. I've been exposed to several things that I believe they've improved my skills in diagnosing and treating patients. In 2010, I needed an upgrade from my film pan-ceph, and I chose to purchase my first cone beam CT machine. Then in 2011, I took my ABO clinical exam. And for me, being board certified, I was a sole practitioner. So just being board certified at that time meant that I had kind of implemented a quality control, not looking at all my outcomes, but at least looking at outcomes when I was 15 years out of practice. And that aspect to my clinical practice was added. In 2014, I started teaching as a volunteer faculty member at Indiana University. I taught both the TMD course and I taught in the clinic. And then in 2016, I opened a newly constructed office. And also during that time period, I was actively pursuing membership in the Midwest Angle Society. The Angle Society has also given me a network of experienced clinicians to look at my cases and treatment outcomes and give me advice. And then in 2020, I opened a new satellite. So in between this time period of 2016 and 2020, around 2017, my practice nearly doubled, in part because a neighboring county practice had sold, transitioned to different management. And so a lot of people from this neighboring county were coming over to our practice. And then in 2021, I did my first DIBS case. So I came across DIBS AI at a GLAO constituent meeting, and it made a lot of sense to me. I was very intrigued by it, and so I started using it, and I've been using it ever since. And then in 2024, we added an associate doctor. So the one thing that I want to mention from this slide is that I was interested in, I had to kind of grow my practice through the years because, again, I said I had to pay bills. Obviously, we want growth financially and in terms of how many patients we have. But I also felt like increasing quality was important too. I wanted to be a better practitioner than I was the day that I graduated. So I think you can't increase both of these things without looking at increasing your efficiency, both in terms of the doctor time that's spent at the chair, and then also the number of appointments that your patients have. So, and during this time, we steadily grew in terms of numbers. So that kind of leads up to the discussion of cone beam. So cone beam CT has really changed the way I practice. This is a whole different lecture, but there's so much information in a cone beam CT scan that I feel is useful for diagnosing and treatment planning. The American Dental Association noted cone beam's ability to visualize teeth and their relationship to each other more accurately than 2D radiography. So one thing I noticed in the early years of using cone beam CT, and probably because I was preparing my ABO cases at the same time, is that in some patients, it's nearly impossible to level the curve of Wilson. So ABO standard grading is ideally pointed toward leveling the lingual and buccal cusps of the upper and lower molars. And to remove balancing occlusal interferences. So while I was at IU, I worked with a resident using cone beam CT data because I started noticing that in some of these patients, the submandibular fossa does not allow you to upright these, especially lower second molars, without putting the roots outside of the cortical bone. So we found when we did this study at IU that about 5% of patients had anatomically, you could not completely upright the second molars. So cone beam CT gives you that perspective and allows you viewing resting tongue posture. That's another thing we look at routinely now that we just couldn't do that before cone beam CT, in my opinion. And it also helps you to see supernumerary teeth. So here we have a supernumerary lateral, but we also had a supernumerary central that, you just don't get that view from a 2D perspective. Cone beam CT also allows viewing of the anatomy of clefts, joints, impactions, and the thing that's pertaining to this lecture is the tooth roots and their alveolar housing. So the important thing to remember when you look at cone beam CT is that now you have a complete 3D view of structures that vary in shape with all kinds of surface irregularities. So as opposed to looking, think of looking at like a cylinder or funnel where everything is symmetrical. Now we're looking at the crowns and roots of teeth, which may look straight from one angle, but obviously they're crooked from another vantage point. So again, I think when we're in excuse me, when we're looking at 2D radiography, we're only getting a glimpse of the total picture. And that's why it's so important to view the cone beam CT data superimposed on the intraoral scan for your setups, again, in my opinion. So intraoral scans are only as good as the care that goes into them. And obviously, the teeth need to be free from plaque debris for good indirect bonding. In our practice, if the patient does not have good oral hygiene at the scan appointment, in my opinion, they should not be bonded. Another key fact is that nothing should change between the scan appointment and the bonding appointment. This means that the patient needs to be carefully questioned and screened about all restorative work being completed. Also, this means that if a patient has primary teeth that are near exfoliation, or actively erupting teeth, you need to wait. Resist the urge to start the patient and just put them on recall for 4 to 6 months. This is the best piece of doctor advice I can give you for successful indirect bonding, is to wait until the permanent teeth are erupted, or at least until nothing is actively erupting, in the eruption process. And then you want to minimize the time between your scan and bonding. In our practice, ideally, I think that's 2 to 3 weeks. That's plenty of time to get us set up and be ready to bond. In our practice, sometimes it leans more toward 4 weeks, but I think ideally is 2 to 3 weeks. So one of the beauties of this system is that you can continue to utilize your favorite brackets, okay, your favorite stock brackets. We use a mini twin, low profile. You don't have to change brackets or purchase a bracket system that is unique to one patient. And using this software, it's very customizable to your patient. So you can put the brackets absolutely wherever you want on the teeth. In our office, we print the indirect trays and we load the brackets, so it's extremely fast. And that way, if for some reason the treatment falls through, the brackets just go back into stock. Remember, one of the things that I think shapes the way I practice is that I practice in a very rural area. So sometimes shipping to our practice location, it takes longer than it does in an urban area. And since I've opened my office back in 1997, I've always had an in-office lab. So this fit very nicely, especially with the fact that we could 3D print the trays and load them. So in our practice, we have the same assistant doing the indirect bonding. I think it is somewhat technique sensitive. You can see here, she's holding the tray in position from the occlusal, and then she's individually lighting each one. Here she's removing the trays. I think it is good to have the same person doing it, but you need to have some secondary people doing it. I mean, it is somewhat technique sensitive, but at the same time, I think most of your skilled assistants that do bonding, direct bonding and prep teeth are going to be able to catch on to this pretty quickly. So this video gives a nice overview of the cone beam scan superimposition process. When I started doing this, we utilized a third-party software to segment our cone beam CT scan into individual tooth roots. You have to get the DICOM files from your cone beam converted to STL files and identify and label the individual teeth and roots. Now DIBS does a lot of this process for you, and it's a very minimal fee, and I feel like it adds so much to your setup. You also have the option of viewing the maxilla and mandible from the cone beam CT scan. Now keep in mind that because cone beam CT scans are captured and assembled in layers, the cone beam CT size is maybe slightly different from the scan, so there may be a slight dimensional difference. And if we have time at the end of the presentation and you're interested, I'll show you kind of what I'm talking about. But it's very close in terms of accuracy. So I'll just let this show a little bit more. Okay. So these 3 mandibular first premolars are from 3 different patients. And again, we had this 2 times ago. There was a doctor that discussed this, and I want to just kind of add to what he said, that there's some anatomical variability, and the bracket position can change root position based on how the bracket is positioned on the tooth and the anatomical variability. So all 3 of these, the superior part of the bracket pad is 3.8 millimeters from the occlusal surface, the occlusal edge. But notice how variable the actual slot is with the height of contour of the teeth. I realize these are slightly different angles, the way these are angled, but this is only for illustrative purposes. So when you engage a wire to express root torque, how variable it will express depends on where the slot is relative to the height of contour on the tooth. And then in addition to that, there may be variability in the long axis of the root relative to the crown anatomy. So using cone beam CT in this software, you're able to visualize and make torque corrections to bracket positions based on these anatomical variabilities. So superimposition of the scan on the indirect setup also helps you to plan for the eruption pathway of unerupted teeth. So let's look at a case. This teen patient is in the late mixed dentition. She has a few primary teeth remaining, and she's class 1, minimal crowding, relatively flat profile, and really not, doesn't appear from the photos to be very difficult. So her cephalometric capture is unremarkable, but here the panel reveals a transposition of teeth number 10 and 11. So what would you do? She doesn't need extractions, and the anatomy and the root lengths of these teeth do not lend well to leaving the transposition in place. So additionally, the parents and the patient, their preference was not to leave the transposition. Sometimes I think that's the only way we can, but doing a setup with cone beam CT and using the DIBS AI software, I think it just gives you better visualization of what's going on. So the transposition of the cone beam CT on the scan shows the erupting canine directly sandwiched between the central and lateral roots. And I realize here that the cone beam CT is not, seated completely down the scan, but the anatomical position of the roots relative to each other is accurate. So, what do you do for this patient? Well, with this setup, I can rotate the view around and notice that there is a small amount of space between the canine and lateral root. I can also move the roots of the central incisor and first premolars away from the path of the eruption of the canine. So I decided not to bond the lateral incisor, extract the primary canine, and expose and bond the canine with retraction buccally and distally. The visual toward the first premolar crown, the visualization is just so much better with cone beam CT in this setup. So when the setup comes back to you, the AI will have set up the brackets in a pretty good position to optimally position the tooth. But sometimes the bracket heights may be slightly different based on the mesial distal position of the bracket and where the center of the bracket lines up with the long axis relative to the incisal edge. So we know there are little surface irregularities in the incisal edges. So using the predicted outcome and the grid, I can visualize the net types of movement across the arch. For example, how the arch will level. So on this existing and then predicted, we can tell that, obviously the laterals and canines are going to extrude a little bit. You're going to get some, with a straight wire, you're going to get some intrusion of the premolars and probably a little bit intrusion of the central incisors as well. And then you can decide, does this plan agree with your smile aesthetics, what you want for the patient? And the bracket positions can be modified to agree with the treatment goals for the entire arch. So here is a lower arch setup, the existing and the predicted outcome. And can you see again, you get a good visualization of how this case is going to level, okay, with a straight wire. And using the outcome simulator, I can adjust the bracket position to help keep the roots parallel during this movement. Another thing I want to point out here is that I use a prescription that has a lot of negative root torque. I like that because I like the ability to, again, level the curve of Wilson. But sometimes when the torque is expressed based on your setup, it almost appears that there's too much torque, negative root torque, and uprighting in the second molar area. especially if we have, like I showed you earlier, a mandible and a submandibular fossa, like I showed you on the cone beam CT earlier. So it's possible to create just a small torque difference and custom base to correct for this. You can see that's exactly what I did in the spot between this picture and this bottom picture. Is I adjusted the second molar, I adjusted the torque just slightly so that the crowns and roots were in a better position. When this adjustment is not overdone, the bond strength is still adequate, and you can correct the crown and root torque to better reflect the anatomy of the alveolar housing. So your treatment plans can become much more detailed from the beginning using the software setup as you do your treatment plan. That's exactly how I do it. I do my treatment plans and my setups at the same time. So we've all had cases like this one where there's abnormal attrition of the central incisors, but yet in the existing, you can't necessarily see how that is going to how that straight wire is going to reflect as the anatomical difference in the incisal edge. So we know the maxillary central incisors are a huge liability in terms of aesthetics. Your eye goes directly to them and notices small discrepancies in shape, size, and the incisal edges. And I'm sure your patients and the patient's parents have pointed those things out too. So in this case, the predicted outcome showed me that as the teeth aligned, the incisal edges were going to look uneven relative to each other. So I was able to extrude this left central incisor by 0.5 millimeter, and then actually my treatment plan planned to modify the incisal edge. So I can talk to the patient from the beginning about, potentially having to do a modification of the incisal edge to make it match better the opposing or the opposite central. And I have the tools to kind of plan ahead. So it's not a discussion that I'm having later on about modifying the incisal edge. To me, that's pretty cool. And just being able to visualize the setup with the cone beam data just kind of brings your treatment plan to life. So that is all I have right now. I'm happy if you want to open my screen and share a setup, or I can answer questions.
Thank you, Dr. Helms. That was great. Let's first start with some questions, and then if people would like to see some of you going through a case, that would be great. So first off, I'd love to start with any questions that people may have. Go ahead and put them in the chat if you do have any questions. I will start off with one question while I wait for some more to come in. Oh, excuse me, someone raised their hand. Let's see. Give me 1 second. Awesome. Zach, you can go ahead and ask your question. Zach, did you want to ask a question? I believe you are muted, Zach.
Sorry about that. Can you hear me okay?
Yes, go ahead.
Oh, awesome. Yeah, doctor, if you wouldn't mind just walking through the process just of the CBCT integration. Did you say it gets superimposed into the setup? I'm trying to learn as much as I possibly can. I'm actually a rep for American Orthodontics, so I'm trying to learn as much as I possibly can.
So like it's funny, just like
So you recognize my brackets.
I do, yeah.
Sure. I can, let me get to a DIBS setup and I'll kind of show you how. Let me bring one up and then I'll share my screen again.
Keep the questions coming. These are great questions that we have queued up.
Okay. So can you see my screen, Kaden?
Yes, yes, we can.
Okay. So I'm opening a case now, and I can show you a little bit how it comes in. So again, in my office, I have an in-office lab. So they've actually already imported the roots. So what happens is we take our cone beam, and I use Dolphin, and our cone beam is exported, the file's exported, and then it's compressed. And when we do our case setup with DIBS, we actually load the cone beam when we enter the case. And then when the setup is done and ready for me to check, there's a gear button down here, and it says add adjust roots. So my lab adds the roots. I'm going to click on this just because it'll kind of show you how it comes in. Okay. So, okay. In this case, we're going to pretend like I just added the roots, and you can see the scan and the roots are a little bit different here in terms of where they're positioned. So if I want to, and I'm going to take the jawbones off for now, just so I can kind of zoom in and show it a little bit better. And you can tell that the roots are high here and they're a little bit back. So if I want to bring them forward, and I'm only doing the upper here, I have upper highlighted, or I can move it down and so forth. So I'm just really kind of getting it where, I can do my setup. But that's kind of how it comes in, and it's not exactly superimposed over it. So you do have to do a little bit of adjusting. Okay. And then let's just say I get it kind of close where I'm happy with it. I can close it, and then it's going to come up on my setup. And so here on my setup, I usually do it side by side. I know everybody's a little bit different. But if I was going to start setting this up, I always am adjusting from the occlusal view first. And so, for example, if I move this bracket a little bit mesially, it's going to change the root position. That's why I do this view first. And you can move your brackets. I use the adjustment arrows. I know some people use this over here. I just like I like to look at it in this view. This is just the way I'm accustomed to do it. And then, I'm looking at all of these, and maybe I want to move the canine a little bit distally now. So, and then maybe, and I'm pretty happy with how those roots are positioned, but I don't like this height. I want to adjust this a little bit. And so on and so forth. Same thing, with the maxillary arch. And maybe I want to move this a little bit mesial. And again, I just go back and forth. Now you can see here that this root, based on the surface, reflects that maybe there's too much torque, and I don't want to have that much torque in my setup. So I'm going to adjust it just a little bit, the base, so that it brings that root forward. And that's the cool thing about superimposing this, is that you just get great visualization as far as what's going to happen on your case. You can tell that the roots aren't all the way seated in the scan, but again, in doing your setup, it's very valuable, just the information that you get. Also, again, like I pointed out earlier, when you're planning an eruption pathway of an impacted tooth, it's so nice to be able to adjust the roots torque and both tip to be able to make a clearer path for that erupting tooth. Does that answer your question?
That was very helpful. Thank you so much.
You're welcome.
Thank you, Dr. Helms. Okay. Next question is, when you play the tooth movement animation, do the roots visually move too?
Yes.
They do. Yes, they do.
I thought they did, but I just wanted to be sure.
Action speaks louder than words, right? I love it. Good. Next question is, when using CBCT, does DIBS take into account root position when determining long axis of the tooth?
I mean, if you look at this, it doesn't look like it does, okay? So again, that long axis may be off a little bit. You know, I'm just looking at this setup, and it is off on some of these. So again, I'm much more focused on the root position.
And Dr. Helms, why are you much more focused on the root position?
Well, because I think it's more accurate. I mean, again, this is a guess, the long axis of the tooth. This is based on artificial intelligence. It's a guess, but if you look here, if you look at this, it's not accurate. The long axis of the tooth is here. So I think that's just the value of having, and I understand you can get root dilacerations, but I think the root gives you a clearer picture of the long axis.
Great. Thank you. Have you seen any differences depending on the brand of CBCT? Obviously, DIBS uses a specific one, but with other CBCTs that you've used, have you seen a difference?
So I'm not sure. Are they talking about the kind of cone beam CT that I use, the machine?
I assume so. The other thing I could guess is
Okay.
Yeah, go ahead.
Okay, so I've only had two cone beam CT machine types, and I've not had them at the same time. So currently I have an ICAP Flex. My understanding is some of the cone beam CT machines actually will do the conversion from DICOM to STL. Mine does not. So I have to have that conversion before this can take place. Also, I've been told that some cone beam CT machines will do the segmentation. Mine does not.
Okay. Thank you. That's very helpful. Here's another good question. When you adjust the torque on brackets, there's a gap either on the buckle or the incisal edge that's meant to be filled with extra glue. Since we know that the thicker the glue, potentially the greater the risk for debonding of the bracket. Is there a limit to how much torque you can add to the stock bracket?
Okay, that's a great question. And honestly, I mean, and again, this is going to sound very, it's a study club. So I've not done a study of if there's a certain amount of glue, does it debond? I have not seen a difference in bond strength. Most of the brackets that debond in my practice are either from non-compliance or of the patient or from, if interference, like occlusal interference, where they're hitting the bracket when they're functioning. So, I don't overdo it because I know ideally you want that bracket pad to be right up against the tooth, but you can do a very small correction and still, I think, have the roots in a better position than just putting the bracket right up on the tooth. So, I mean, I don't know if that answers the question, but I've not seen an increase in debonds with doing some bracket pad customization.
That's good. That's good to know. And for everyone else that's watching, we did another study club in October, I believe, last October that was on custom bases that was done by Dr. Martin.
Yes.
And he talks about that, and it was an incredible, just like this was an incredible study club. And I would highly recommend those that are asking about that to go look at that. And then anyone who is coming to AAO, come visit our booth. We have some extremely exciting information about custom bases and stuff like that. So be aware of that. But great question. Thank you, doctors. Next question is, in an impacted tooth case, do you end up direct bonding the lateral incisor and canine ladder, or is there a way to integrate that into the treatment plan?
Okay, that's a good question, but in the case that I showed you, we're actually to the stage. I just started that case within the last 6 months. So the transposition is corrected, but I wanted to make sure that the canine crown was obviously past the root of the lateral. And so we are just planning to direct bond the lateral and the canine at the next visit. So there's not, to my knowledge, there's not a way of going back and reintegrating it without doing another setup, which means you would have to rescan and, you know, redo a setup for those two. But that's a great question.
Great. Thank you. Another question here. If you can show us a case on how to do the CBCT case setup, that would be, I guess you just did that. So we can go ahead and check that one off. A logistical question. Let's say you do a consult taking the CBCT in photos, but they then reschedule their start, let's say 6 to 9 months later. Therefore, the iTero scan would be up to date, but the CBCT may not. How often do you take those CBCTs, being careful of the patient's health?
Okay, that's a great question. So here's the way we do it in our practice. We take photos, and before I go, I look at the photos first. And if the patient is not ready, like for example, if they have some primary teeth or they have some actively erupting teeth, we do not take the cone beam CT scan. So we try to match that cone beam CT with the scan. Now, that being said, let's say, for example, that a patient, you took a cone beam CT and for whatever reason, they decide they don't want to start and they want to start 6 to 9 months later. You can still use that cone beam CT scan, but the roots that are, obviously there's going to be a little bit of a mismatch if teeth have erupted since then or teeth have changed position or whatever. So I guess the first answer to that question is I try to wait to take the cone beam until I know the patient's ready. The second part of it is if you have to take your scan later, then you still can match the cone beam with the scan. If there's a discrepancy between the scan and the root, sometimes the root won't be superimposed, like it'll just drop that root off of the setup. So the worst case scenario is maybe you're missing one of the roots, which isn't great, but in terms of being considerate of your patient's radiology exposure, you know, to cone beam CT, I would not retake the scan. Or not retake the cone beam, I mean.
Thank you.
You're welcome.
Good. Thank you. Good. Dr. Liang, I'll go ahead and allow you to talk.
Okay, thank you.
Yeah.
So, Dr. Helms, thank you for that really informative presentation. I just started using DIBS maybe a month ago, and I've been so happy with it, especially the CBCT integration. Having you went over some of those key points. I just wanted to get your perspective, like how many degrees of torque do you feel comfortable doing on DIBS? Is it 5? Is it 10? Is it 40?
You're talking about in terms of if I change the torque,
Yes,
like I did the lateral. Well,
right.
yeah, definitely not 40. I mean, again, you can you can add your maxilla to this. Okay.
Mm-hmm.
So
Yeah.
you can see, what is going on. Now, clearly, when on this setup, it looks like roots are, out of the bone and so forth, which we know doesn't happen. Again, keep in mind that the scan is not completely superimposed over the or the cone beam is not completely superimposed over the scan here. But, I think if you've got a question on how far you want to go, you can always superimpose your maxilla or mandible.
Mm-hmm.
Again, just to get a visualization. But the reality is, I mean, and you know this, I mean, when you are direct bonding, or if you're not superimposing the cone beam on it, you don't even have that perspective to begin with. I mean, you
No,
really don't even have a roadmap of what you're doing.
no, not at all.
So what I would do is if there's a question, if you want to put a lot of torque in your setup, go back and superimpose your maxilla or your mandible. So you at least have an idea of how far the anatomy that you're working with.
Yeah, I think actually what you said was we know that that's not really where the teeth end up within the bone because that's how I thought the teeth were going to end up in the bone. And I had two cases of patients who were kind of bimaxillary protrusive, but they didn't want extractions where the canines would have ended up completely outside of the maxilla. So I got really scared and I torqued them super palatally to avoid coming outside of the bone. Now I know that bone will follow the root
Mhm.
as long as it's not the apex. So this like 4 and 5, I'm not really worried too much about, but those canines were completely out of the bone. It was really frightening. So I just I just want to know what was my limit. I mean, I bonded this girl with ceramic brackets with a ton of glue on her threes and she's fine, like
Mhm.
they stay stuck. She hasn't had any complaints. But I was just wondering if anyone else encountered that. So I'm glad you said the thing you said about how we can't take the superimposition of the maxilla or the mandible at face value like that because
Yes,
like that would be really frightening.
yes, yes. Yeah, because what doesn't simulate here is the maxilla and mandible. It's not going to simulate how how these roots are going to, how the changes in there. Obviously, the roots are going to move, but you don't see the change in the bone.
Right, right, exactly.
Mhm.
So as long as it's not like you're putting the apex like head first into the, alveol like the buccal plate of the alveolus, it's okay.
Yeah,
So,
yeah,
yep,
agreed.
totally.
Good observation.
Thank you.
Mhm.
Thank you, Dr. Liang. One thing that I do want to mention is we had a question that that asked if the DIBS technicians set up the CBCT roots with the STL crowns, or if it's up to the doctors. And Brittany, who is on here as well, she's our software expert, mentioned that our technicians do get them as close as they can, although sometimes the scans can be distorted, and so we do our best we can, right? The technicians do get it as close as they can.
Mhm.
But then we do ask the doctors to go in and just verify it or approve it, right? Just like they approve any other case. So, good question. Couple more questions, and then we will wrap up. Have you seen a true decrease in number of repositions in the midst of treatment since using CBCT integration? Have you also seen a general decrease in treatment time?
Yes and yes. There's just no question, my standard way of practicing has always been that once we get the case kind of initially aligned and leveled, that we would take a pan and we would check the roots and do some repositioning before we got into our finishing wires and before we want to get those roots as parallel as possible. I mean, again, that's how I was trained. So whenever you have this capability, I mean, clearly you can see what you're doing in terms of root paralleling from the beginning. So, we went, again, I would say an average based on adjusting the tip of the tooth, maybe 4 or 5 brackets per setup. And now there are probably an average of one, maybe none. There are times that we have no brackets to reposition. I mean, the setups are very, very accurate. So definitely, if you don't have to stop and reposition brackets and go back maybe to a lighter wire and go through your wire sequence again, it's going to be more efficient in terms of finishing the case. Now, I always talk about bottlenecks. There are always bottlenecks in treatment. So, I'm talking about your average slight crowding, maybe 50% overbite, minor class 2 case, yeah, those cases are going to finish up faster. But if you have a severely impacted tooth that is going to take 12 months to bring in, well, no, those cases aren't going to finish faster because the bottleneck of treatment is the impacted tooth. So it's case specific, but generally this definitely increases efficiency, both in terms of reducing repositioning and also lessening the time that they're in treatment. And I would say maybe not in terms of, we may let them go a little bit longer. We may let them go like 8 weeks instead of seeing them in 6 weeks. So maybe there's still a 20-month case, but especially in terms of how many appointments they have to have.
That's very, very helpful, Dr. Helms. Thank you. And we have some studies that we are currently working on that shows this data. And I can tell you from analyzing this data and being the one that is collecting it, there is significant decrease. So if you're on the edge, listen to Dr. Helms because she's 100% right, and we have some data to back it. One thing, let's see, please tell us about your feedback with the IsoGlide spring for the high canine case.
So I'm not sure I understand the question, because in that high canine case, what happened was it was transposed, and it was kind of between the central and the lateral. So the reason I brought that case out was because I could visualize on my setup where and kind of create a path for bringing that canine in. It was just bonded with a standard gold chain and bracket. There wasn't a spring on it. And then we just tie the chain back to the premolar. So, but the point on that was, if I just went from the pano, again, back in the 2D days, I would have no idea how much resorption was going to be on the lateral root. I didn't really have a great capability of moving the first premolar and the central roots kind of out of the way as the canine was moving down. I couldn't visualize it. So with this, you have a better way of visualizing the path of eruption of that tooth and planning for it.
Perfect. Awesome. We got 5 more minutes and we still got questions coming in. Are you doing good, Dr. Helms?
I'm doing great. Yeah.
Lots of questions for you today. I love it. One of them says, how do you speak to parents about the necessity of CBCT for IDB if they are questionable about x-rays to begin with?
Okay, so again, I'm very comfortable with the machine that we have now, speaking about radiation exposure, because the amount of radiation exposure that they're getting, again, is much less than if they had a CT at the hospital. I think it's like 1/30th of the amount of radiation, and is even less than putting their child on an airplane. So I want to be respectful to parents' concerns, but the way we talk to parents about it is we just give them some equivalence of radiation exposure, that their child probably is already being exposed to. Okay. And then we also talk to them about, in terms of the scan, the scan that they're having, they're not really having radiation exposure from that. So we basically tell them, that we can get the brackets on in a more accurate place. We can plan better considering the natural anatomy of their teeth. You know, we also can see the place where the root should be within the bone easier using this technology. And in our area, we don't get a lot of pushback from parents. I mean, they see it, they're able to see that, you know, what we're talking about. And I use the same conversation when I talk to them about waiting until the teeth are completely erupted. I tell them, look, you know, if we wait, then we'll be able to very efficiently get the brackets positioned across the whole arch. Otherwise, some of these brackets, we're going to have to wait, you know, until the teeth come in, and then we're going to have to do some guesswork in terms of positioning them. There's just nothing better than bonding upper second molars using indirect bonding with DIBS. There really isn't. There's no way I can get that bracket in a position where, you know, it's even really centered, let alone that it's going to position the root where I want it to be. So, I mean, it's not a difficult conversation. And in terms of the cone beam, yeah, I understand the concern, but we just compare it to everyday things that they're familiar with.
Great answer. Thank you. Do you normally bond the sevens if they are erupted at the start of treatment? If so, how well have you seen them stay?
We do. I mean, again, I just answered that. My preference is certainly to bond them if they're erupted. And they are, I think the key is isolation. But when you print these trays, you know, we're talking about usually from the first premolar back to the second molar. So again, one of the beauties of this is that you're only isolating a section of teeth. So I think it's easier, and so I mean, so do the people that do the indirect bonding, to isolate just a section of teeth and make sure that they're clean, make sure you can visualize it. And again, the whole key, and I think this was mentioned in the previous study club that you had, the whole key is making sure that that tray doesn't rock, that there are no gaps in it, and it indexes directly on those teeth. And so the best way you're going to do that is just making sure that your scan is accurate with the day that they're bonded, and you don't have teeth actively erupting, or there's no restorative in between there. But yeah, that's my preference, is to get on the second molars right away.
Perfect. Awesome. And then pretty similar question. Do you ever use this for phase one or more full treatment of all erupted teeth? So as you said, you love to use it for all erupted teeth.
Yes, and I don't use it for phase one. You know, I'm still doing direct bonding, like for a 2x4. But again, you're talking about a limited number of teeth that I can see a little bit easier, I can visualize compared to posterior teeth. So I don't use it for phase one.
Awesome. Thank you, Dr. Helms, and thank you all who have joined and participated. We truly appreciate it. We love these study clubs, and they continue to grow every month that we do them. So thank you for joining. Thank you for hopping on. If you want to watch this again or share this with someone else, you can find it in the support tab on dibsai.com under the deep learning portion. So we will be back again next month with another study club. And once again, thank you to Dr. Helms. Have a great rest of your night, everyone.